congratulations for the kind words. At the outset, I must thank Dr. Banshi Sabu, Dr. Sanjay Agrawal, Dr. Vasant Kumar, and the organizing committee for giving me this opportunity to talk on this topic. So before going to the main topic, let me put up the slide of the current status of COVID globally as well as in India. So globally, as of now, 25 crore people are infected with COVID-19, and we had around 5 million deaths over last 2 years. The number of deaths in India is also around 500,000. So that's a big number. That is the kind of mortality that we had in 2 years. But let's not forget that the biggest killer still remains ischemic heart disease and stroke. So this is the data from WHO, the recent data. In 2019 alone, we lost around 8.9 million lives to ischemic heart disease. And if you add up stroke, then the combined figure becomes more than 15 million people. And there has been a rise of around 40% in the mortality if we compare the numbers in last 2 decades. The numbers in India are not much different. If we combine the deaths due to ischemic heart disease and stroke, we lost around 2 million lives every year. So these numbers are really too high if you compare the mortality of COVID-19, though it's an infectious disease and that's why it receives a lot of attention. But let's not forget the biggest killers here. Now, we all know that this doesn't happen in a day. Atherosclerosis is a process that takes years together. And in this process, if we can identify people earlier in the course, and if we can intervene somewhere earlier, probably we can prevent the development and progression of atherosclerosis, and we can avoid a lot of deaths. So how do we identify the people who are at risk of getting atherosclerosis or cardiovascular disease in future? Now, this is the infographics from WHO, and I'll zoom in the area which is talking about the risk factors of CVD. The risk factors, we all know about them, but the few like high blood pressure, high blood sugar, high triglycerides, low HDL, and central obesity, these usually come together. There's a conglomeration of these risk factors, and that is what is called as metabolic syndrome. So a conglomeration of central obesity, insulin resistance leading to high fasting plasma glucose, hypertension, high blood pressure, high triglycerides, and low HDL. That is what is called as metabolic syndrome. So what is so specific about visceral obesity? Why does visceral obesity have such an important role in causing metabolic syndrome? That is because the blood from visceral compartment is drained directly to liver through the portal vein as opposed to the peripheral fat. And that is how the liver is exposed to the metabolites of adipose tissues in the visceral compartment. So now, this is just a slide of the mechanism. How does it happen? So the obese people, we know that they are insulin resistant. One of the actions of insulin is to prevent the intracellular lipolysis. So because of insulin resistance, that action is not happening properly, and that is why there is lipolysis in the intra-abdominal adipose cells, and that leads to release of large amount of free fatty acids and triglycerides. These free fatty acids, they go to liver and they cause inflammation there, which leads to insulin resistance and fatty liver also. The liver is also exposed to large amounts of triglycerides, and that is why the VLDL particles which are released from the liver, they are rich in triglycerides. Now these VLDL particles, they exchange this triglyceride with the HDL with the help of CETP, and that is how the HDL particles become dense in triglycerides and small in size, and these are excreted through the glomerulus. Also, the triglyceride is exchanged with the LDL, and that is how the LDL particles, they become small and dense. So this is the mechanism by which we have large amount of small dense LDL particles, low levels of HDL2, and high levels of triglycerides in patients who are centrally obese and have insulin resistance, and we all know that is the atherogenic milieu of lipids. Now these small dense LDL particles, they easily enter the endothelium and they get oxidized. They release the cytokines. MCP1 attracts the monocytes enter the endothelium, and then they are engulfed by the macrophages. Again, cytokines are released, adhesion molecules are produced, and the vicious cycle sets in wherein you get more and more monocytes entering the endothelium. The macrophages form foam cells, and we all know the rest of the story, that leads to atherosclerosis. So this was the theory, but is it really relevant? So this is a study which was done from the enhanced data, and this is a histogram. If you look at the right extreme of the histogram, the chart is for the people who had diabetes mellitus and metabolic syndrome, and the prevalence of CHD is the highest in that group. But look at the middle two. The the one that is about the people who are having diabetes only but no metabolic syndrome, their incidence is still lower than the people who are having metabolic syndrome but no diabetes. So we all know that diabetes is a coronary risk equivalent, but that is largely because of the parameters of metabolic syndrome which come with diabetes. If you look at the people who are only diabetic but do not have metabolic syndrome, they do not have that much of risk of CHD. People who are having metabolic syndrome but without diabetes have a higher risk of CHD. So that is just to highlight the importance of metabolic syndrome. Now, this is the study, Copio heart study, which was done in middle-aged men. And here again, you can see that the all-cause mortality, the cardiovascular disease mortality was significantly high in patients who had metabolic syndrome, the relative risk being 2.13 and 3.55 respectively. Now, in this study, which was done in around 6,000 men, they have looked at the contribution of various factors of metabolic syndrome. So, in this graph, the top one, the pink one, is for the people who were having 4 or 5 components of metabolic syndrome. That group had the highest risk of getting new onset diabetes, which was 24 times the people who do not have any component of metabolic syndrome. And the risk of CHD death and non-fatal MI was also significantly high, to the tune of 3.65 times the people who do not have any component of metabolic syndrome. A similar study done in patients who were post-CABG patients, and they were followed up for around 10 years, and their survival was seen. So again, as you can see, the lower graph is for the people who had 4 components of metabolic syndrome, and their survival was the poorest compared to the people who did not have metabolic syndrome. In this study from France, they have looked at the outcomes in patients who were admitted with acute MI. And again, you can see for different parameters like death, CHF, cardiogenic shock, patients who are having metabolic syndrome, they had a significantly higher risk compared to those who did not have it, though the risk was not different for ventricular tachycardia or ventricular fibrillation. Now, this metabolic syndrome was discussed a lot earlier, but in between, after the IDF definition was released, Scott Grandy was the person who came up with the idea of metabolic syndrome. He published a paper saying that metabolic syndrome is not relevant because it doesn't add up to any additional risk by having metabolic syndrome than there is that the individual components have. So this study clearly shows that if you look at the individual components of metabolic syndrome, they have some association, but the conglomeration of all these factors as in the form of metabolic syndrome actually is more important and gives more weightage. So there are several definitions for metabolic syndrome. I'll touch upon those in the next slide. The risk of all-cause mortality, fatal CVD, non-fatal CVD, MI, non-fatal MI, all the risk is significantly high. Now, this is a study in which they have 13,000 participants, and they looked at the sudden cardiac death. So again, you can see the risk of sudden cardiac death over a period of 25 years, which is a long period. The risk of sudden cardiac death is significantly high in people with metabolic syndrome. On the right side, they are comparing the people who are having 1, 2, 3, or 4 plus parameters of metabolic syndrome. Again, you can see as the number of parameters goes up, the risk of sudden cardiac death goes up. So there are n number of studies looking at this aspect, and this was a meta-analysis of different studies looking at the cardiovascular outcomes in patients who have metabolic syndrome. And from this forest plot, it is very clear that every study shows that they have a higher risk of CV events. What about stroke? This is a meta-analysis looking at the incidence of stroke. Again, the number of people, the participants is over 100,000. And with such high population in this meta-analysis, you can see clearly that the risk of stroke is also significantly high in people with metabolic syndrome. What about CKD? Now, this study, again, the number of people, you can see it's a huge number. And this is a meta-analysis of 66 studies. Again, the risk of CKD is significantly high in people with metabolic syndrome. And in the lower part, you can see they have looked at the components of metabolic syndrome. So the people who are having all the 5 components of metabolic syndrome had the highest risk of CKD. The risk for liver-related disorders, again, this is a meta-analysis clearly showing that they also have a risk of liver-related outcomes, adverse outcomes. Now, let's talk about COVID. COVID is the recent thing that we have witnessed, and this is a good study in which, this is from China. Again, they have looked at the cumulative survival in people who were admitted with COVID and had the components of metabolic syndrome, and the lowermost graph is for the people who had all the components of metabolic syndrome having the poorest outcome in the 50 days follow-up. So metabolic syndrome definitely is a very important entity. I can't cover all the slides in this short time, and it has been named differently, but there are different synonyms for metabolic syndrome. We'll stick to the one which is commonly used, that is metabolic syndrome, and there are several definitions also. The first one came by WHO, then the European Group for Insulin Resistance, they came up with their different definition. Then the NSAP ATP3 came up with a definition. This definition was very popular and was endorsed by the ADA, many of you would remember. As per this definition, metabolic syndrome was defined as presence of 3 or more of the 5 parameters: central obesity, low HDL, high triglycerides, high fasting, and high blood pressure. Now, in this the definition, there were several problems. The most important being the cutoffs for waist circumference for defining central obesity. They were not applicable to the other countries. These were very high. So Dr. Anup Mishra's group from India and several other people from different countries, they did studies and they came up with different cutoffs for their own countries. The other important issue is that in this particular definition, central obesity is not the essential component. So that is why if you have a patient whose fasting is uncontrolled, he's obviously going to have a high TG, he's going to have low HDL, and you might falsely label him as a metabolic syndrome, though central obesity is the key conspirator. So that is why global consensus definition was released by IDF, in which they defined metabolic syndrome as presence of central obesity plus any 2 of the other 4 parameters. The central obesity was defined by race and gender specific cutoffs for different countries. Now, the issue which was very simple to identify people or screen people at risk has become complicated. Now, it's very difficult to teach a student to mug up this whole definition. So, we can't ask the physicians to remember all these parameters. So, here we did a study. We analyzed the waist circumference cutoffs for different countries as suggested by the IDF definition, and we looked at their average heights. The finding was that the requirement for different cutoffs for males and females and for different countries is largely because of the difference in their average heights. So if you just take a ratio of waist circumference and height, probably you can do away with the different cutoffs. So this was index of central obesity, which was a novel parameter which we proposed in 2006. And after that, we proposed a simplified definition of metabolic syndrome, in which it was defined as central obesity being index of central obesity more than 0.5 plus any 2 of the other 4 parameters. We also validated this definition in our own population, and we found out that it was having a very good specificity and sensitivity for identifying people with metabolic syndrome. Additionally, there was one more additional advantage of this definition. There were people who were short, and because of being short, their waist circumference was low, so they were not picked up by any of the definitions. But in our definition, we use the height also as a parameter, and that is why we were able to pick up a lot of people who were missing earlier just because they are short and having a low waist circumference, but they had central obesity. Another advantage of this definition is that you can apply it in children as well, because in children you can't have a same cutoff for waist circumference, but if you are taking height into consideration, you can use it for children as well. Then again, we did another study in which we looked at whether we can have a common cutoff. So as you can see on the left side, these were the people who had metabolic syndrome as per the existing definitions. So females had the waist circumference of more than 80 and males had the waist circumference of more than 90. But when we looked at their index of central obesity, it was at a common cutoff of 0.51. Again, proving the point that you can have a common cutoff for both males and females. So this paper was published along with Dr. V. Mohan and Dr. Shashank Joshi, where we suggested that probably we can replace waist circumference by index of central obesity in defining metabolic syndrome. This paper was also critically reviewed by independent experts. And then there were several other studies from independent investigators from different parts of the country looking at the utility of index of central obesity in defining metabolic syndrome and looking at the future risk of cardiovascular diseases. In this study, they looked at the vasculogenic erectile dysfunction and the role of ICO in predicting the risk. And then there are several other studies in which the people have looked at its utility for different purposes in defining metabolic syndrome as well as for predicting the risk of CV events. This ICO also gives a very useful message for the community. You can simply tell the people that you have to limit your waist size to half of your height. That's a very simple message to communicate to the people. Secondly, you can always tell people that if your waist circumference is more than half of your height, you are at a risk. So go to a doctor, just check your blood pressure, fasting sugar, and probably lipids, and you can pick up these people earlier. It will also help us in screening the people. Selected people should be screened rather than doing the universal screening. So there can be a lot of future work that can be done on this particular parameter. We can look at the utility of this index of central obesity as a pre-screening tool. Probably we'll have to do a study to say that if we just screen people who are having ICU more than 0.5, we will be able to pick up the most of the patients. Secondly, we can probably think of developing a risk score based on index of central obesity, family history, and age. These are the 3 clinical parameters. You don't need any test for these. You can just develop a score and people can check their own risk of getting this disease. And recently, I think most of you would be aware that 2-3 days back, a paper was published by Dr. Anup Mishra, Dr. Banshi, and Dr. Shashank, where they suggested that the minimum age for screening in India should be lowered down to 25. But screening the huge population of 130 crore, and among those, all the people who are about 25 might be a difficult task. But probably if we also consider ICU, family history, and age, and then find out the cutoff for age, we can probably get an age that somebody who is having the ICO, which is more than 0.5, he requires to be screened at particular age. Person who is having family history needs to be screened from this age, and people who have both of these probably need to be screened at even earlier age. So to summarize, metabolic syndrome has a very strong correlation with CV risk and can be used as a screening tool to identify people at risk. Index of central obesity is a better parameter of central obesity, has a better correlation with CV risk, and can be applied to children as well. ICO cutoff of 0.5 can be used regardless of race and gender universally, and anyone with a waist size of more than half of height should be further investigated for workup of metabolic syndrome. So I'll end my talk with this slide of evolution. Many of you must have seen. So as the diabetologist, as the association RSDI, it's our responsibility to try to reverse this global change in the human architecture that we are having right now. Yesterday night, Dr. Banshi was talking to me, and he was talking that probably after a few years, we'll just have people like the last one, and that will be considered as a human being. Others will be rarity. So let's try that we can reverse this. Thank you. Thank you very much.